In terms of ejaculation, I think you're on the guidelines for ejaculatory dysfunction. Let's first just start off with what's normal in terms of ejaculation, in terms of the amount, the color, the texture, because people have a lot of questions about that.
Yeah. So we get a lot of penocentric, genitocentric, semenocentric patients in our practice. I'm in Manhattan. A lot of very high adrenaline patients coming in, very distressed about their sexual problems. So from a volume standpoint, it's 1.5 to 5 cc's would be considered normal. The longer the period of absence, the more semen you're going to produce. But this idea that, you're producing a liter of semen is incorrect. It's basically a teaspoon, okay, for the most part. From a color standpoint, the color is going to vary based on the abstinence period. But there are two colors that you need to be concerned about. One would be red, so blood, hematospermia, which 98% of the time is the result of a benign issue, but there are cancer issues that are associated with that. That is surprisingly more common than many humans believe, but we see a lot of that in our practice. And then the other would be black semen. And I work at a cancer center. We've had, would you believe, over the last several years, 2 cases of melanospermia, right? Where men actually have a seminal vesicle melanoma. Okay, so as rare as that would be, black is a bad thing. If you have bright red blood in your semen, don't freak out. Okay, it's nearly always nothing to be overly concerned about. And that, just like a bruise, that blood will go from bright red, it will change color over the ensuing period of time. If a man in our practice has a persistent hematospermia over 10 ejaculates, and it's not over the period of time, that 10 ejaculates might be 10 days or it might be a month, but then we'll kind of opt to get an MRI. We can then get a digital rectal exam to check their prostate. We do some blood work, but the MRI would be for us the kind of go-to imaging. There are some urologists who use a transrectal ultrasound, but I think the MRI in its 3T format is probably more accurate. Certainly if you want to look at seminal vesicle structure and stones in the prostate, stones in seminal vesicles and blood. So from a color, and would you believe odor and even taste standpoint, we get these questions in our practices, as you know. I really try and encourage people to stop paying a lot of attention to that. Okay. Taste, for example, will change with ingestion of foods, the whole asparagus versus citrus fruits concept, right? And I think from a color standpoint, anything other than red or black, or brown, as the blood changes, I just wouldn't be concerned. My semen is more yellow. My semen is more watery. Semen is a very interesting product. People think it's mostly sperm when it's 5% sperm, right?
Right.
And it's 20% prostatic fluid, and it's 85% or 75% seminal vesicle fluid. And depending on how much of the semen is from the seminal vesicle versus the prostate, its consistency and its color is going to change.
And just for the providers listening, because I'm sure a lot of primary care doctors, even urologists, get the question about, the blood in the semen. If they're ordering an MRI, if it persists after 10 ejaculates, is it a 3T MRI with or without contrast?
We do both with and without. Okay. And so the other thing about MRIs, pelvic MRIs, and particularly, prostate type MRIs, is I had an MRI done. The reader of the MRI is just as important.
Absolutely.
So it's not just the technology, it's make sure that is read by somebody who specializes in, probably the best group will be the prostate MRI guys.
Yeah.
And of course, at Memorial Sloan Kettering, some of the world authorities there, right? So I had a single body MRI radiologist read all of my MRIs for penis and for a hematospermia.
Great. So I would say if you don't know, find out where the prostate cancer doctors are sending their patients for MRIs, and that's probably a good bet. Let's talk about ejaculatory dysfunction.
Yep.
So premature ejaculation is one of the biggest insecurities of men, meaning not lasting long enough, having an ejaculation before you'd like to. What, in terms of premature ejaculation, do you offer to men? Most of the treatments we have are sort of off-label for these things.
Yeah. Let's talk about the definition of premature ejaculation. So there is lifelong premature ejaculation, which is ever since I started ejaculating, I'm rapid. The International Society for Sexual Medicine would define that as ejaculation within about a minute, most of the time, that causes personal distress and or relationship discord. So there are a number of components of it, right? Yep. So the classic example is a man who comes in who says, I was married for 25 years. I always came within a minute. It was never a problem because my wife came even sooner, right? And then he's got a new relationship. And his new partner has an orgasm, his female partner has an orgasm in 7 minutes. Now he's got premature ejaculation, right? So it's not just about the time, okay? The other group are the men who have acquired premature ejaculation. And there are men who, for all their life, they've been fine. And a year ago, all of a sudden, they started coming more rapidly, okay? And that's usually within about 3 minutes will be the general definition. Again, with relationship disorder, personal bother, et cetera, et cetera. And that is predominantly an adrenaline-mediated phenomenon. There is some literature suggesting that hypothyroidism is associated, or chronic pelvic pain disorder, type 2, PB, prostatitis, is associated. But really, the vast majority of men in my practice who have secondary PE, have acquired PE secondary to erectile dysfunction. So because they've got problems with their erections, because they got loss of sustaining, they're working harder and quicker to try finish off before they lose their erection. And that just hyperstimulation, and they just get themselves into rapid ejaculation. From a treatment standpoint, there is no, in the United States of America, FDA-approved drug. There are 3 approaches, as you well know. There are psychological, mental health approaches that are grouped under the umbrella term sensate focus, things like stop-start, squeeze technique, etc. They have very poor long-term consistency of benefit. So if you look at the literature, you're probably looking at a 25% success rate at 2 years after you've started doing that. So you have to kind of consistently do that if you're a lifelong PE. That's typically coordinated by mental health professionals, specialists in our space, in kind of the psychology sphere. That requires a patient and a partner to commit to doing these.
Yes, so the partner needs to be on board.
100%. So now you have a 35-year-old couple with 3 young kids at home who have sex once every 2 weeks, and now they have to devote that sexual encounter to exercises, which is actually hard to comply with. The second group of treatments are transdermal agents, so sprays, gels, creams, which have local anesthetics in there. The ones that are over-the-counter don't have fantastic permeators. There are more non-over-the-counter based agents that have special permeators. So, for example, the absorption pharmaceuticals agent Promescent has, if you've ever smelled that, it smells like thyme, because there's thymol in it, and thymol is a permeator which drives the local anesthetic across the skin. It's a balance between making somebody insensate and not able to feel anything, and making them just insensate enough where it's going to dull the sensation and prolong ejaculation time. They probably, in my practice, and there's really not great literature on this, right? Really probably 1 in 2 chance to make a significant difference to these patients. The mainstay of treatment, and again, not FDA approved, it's off-label, are the use of SSRI medications, right? So selective serotonin reuptake inhibitors, which really have a phenomenal benefit in patients who have at least lifelong PE.
Yeah.
Lifelong PE is a neurochemical disorder. It's a serotonin disorder, and that's why SSRIs work. Okay, so the literature will, if you look at it critically, improvement in latency time from the time of penetration to the time of ejaculation. That's called latency time, and 100 to 600% improvement in ejaculatory latency time. Now, it's not likely that that patient is going to go to 12 minutes. Right, the guy comes in and says 30 seconds. Right, it's not likely they're going to go to 12 minutes. But we certainly see people go to 2 and 3 minutes, and of course, in a relationship that's distressed because of this, that's a big benefit to this man. They're not drugs without side effects. The SSRIs that work best are probably the first generation. Right, so the Prozac, Zoloft, Paxil, so fluoxetine, sertraline, and paroxetine. I use fluoxetine because it's effective, but it also probably has lower side effects than some of the other SSRIs. The best drug around is clomipramine. Okay, very clear from the literature. Clomipramine is an excellent drug with the highest side effect profile, so we just don't use it. And that will be kind of an overview of the treatment. It is a not on demand. There's a lot of interest in it. Well, I just take it 4 hours before I'm going to have sex. They are receptor modulators. You need to modulate the receptor, and whether it's depression or PE, the SSRI needs to be on board for probably 2 to 4 weeks before it really is manifesting its greatest effect on the receptor. So it just doesn't make a lot of sense that people are using these drugs on demand. The other group of drugs there's a lot of interest in for PE are PDE5 inhibitors. Right? So Viagra, Levitra, Cialis, and Stendra. And I think for the man with secondary PE, so acquired PE, secondary to ED, This makes perfect sense.
Yeah.
Okay. And that's the group of men in who we're going to work on your erections first. And I'm going to tell you, you're going to see an improvement in your ejaculatory latency.
Yeah, absolutely. And the other one that I think is less often discussed is delayed ejaculation.
Yeah. Delayed orgasm is a really fascinating concept. So more than 90% of all causes of delayed ejaculation are related to one of five things, or a combination of those five things. One is SSRI use. So there are men who don't have premature ejaculation, who are on women who are on SSRIs for depression and anxiety, and they have such a prolongation in their ejaculatory latency time that they actually, some of them are anorgasmic. Okay, so we always explore: are you using an SSRI? Oh yes, I've been on an SSRI. How long have you been on it for? I've been on it for 20 years. How long have you had premature ejaculation? A year. So clearly that isn't the cause, right? So you want to look at the chronology of the use, the overlap between the SSRI use and the timing of the ejaculatory dysfunction. Number two will be low testosterone. Mauro Maggi, who's a world-famous endocrinologist from Florence, has some very interesting data that if you look at men who have delayed orgasm, that they're more likely to have low T or be in the lower tertile, lower third of the normal range. So we always check T in these men. Number three would be penile sensation loss. So the classic group there would be diabetics, for example. So they got a sensory neuropathy, glove and stocking. Remember, for clinicians, glove and stocking neuropathy, you always want to ask about penis because it's an extremity also, right? So diabetics. The other group at a cancer center are men who have neuropathy secondary chemotherapy. So our testis cancer patients who are treated with cisplatin, for example, some of them will end up with at least temporary glove and stocking and penile neuropathy. Number four, we group into a group of conditions that we call hyperstimulation syndromes, which includes idiosyncratic masturbation, which we talked about a little bit before, but also men who have the death grip or who are 2 hours of masturbation at a sitting or 4 times a day, and the penis just becomes desensitized, right, to stimulation. And then number five is psychological, right? And I say to our trainees that psychological sexual dysfunctions, any psychological sexual dysfunction, is a diagnosis of exclusion. We first want to rule out the other organic causes. So our patients who come in are asked about SSRIs. They get a T level checked. We do penile vibratory sensation testing. That's called bioesthesiometry in the office. There's a nomogram for that. We ask about masturbatory practices. And if all of those are normal, then generally I'm very comfortable saying to them, I believe this is psychologically related. Now, what's very interesting is if you ask men about their orgasmic capacity on their own versus with a partner, and they say, no, I'm fine on my own. It's just with my partner. There are only two causes of that: penile sensation loss and psychological. So bioesthesiometry will tell us very rapidly, right? And when I was in my first day in medical school, the professor surgery came in and talked to us and says, you'll make 80% of your diagnosis by talking to people and examining them. And in sexual medicine, the more you talk to people, the more you find out over the course of your consultation. My initial diagnosis in my mind of psychological sexual dysfunction, as you keep talking to them, it just becomes confirmatory in the vast majority of cases.
And I wanted to go back to the low testosterone. Does replacing the testosterone actually improve the delays?
So that's an excellent question. So we're presupposing if somebody has low T and they've no other overt cause of delayed orgasm, that must be the cause. I'm going to tell you in our data, and this is not yet published, okay, manuscript in preparation. Only 1 in 4 of those men with low T who got delayed orgasm are improved. Their latency time is shortened by going on testosterone therapy into a physiologic range. And so I think that realistically speaking, most people with delayed orgasm have more than one factor. And I suspect just like ED, they've got an organic factor, let's say, but there's a psychological component, right? And so I'd say to patients, you have an orgasm, male or female, when you're in the zone. And when you're out of the zone, anything that distracts you is going to decrease your chance of having an orgasm. So, for example, I'm worried about getting hard. I'm worried about staying hard. I'm worried about, am I going to have an orgasm tonight? So one of the strategies we try employing in our patients, we try have them defocus on orgasm, explore intimacy with their partner, enjoy the encounter, put orgasm off, not worry about it. And some of those patients actually, when they defocus, they're able to have an orgasm because they're not, hyper focused on, am I going to have an orgasm? The other thing we ask men about, particularly older men, is you've got definitely having an orgasm now. That started 2 years ago. 20 years ago, how long does it take you to have an orgasm? And how long was your encounter? My encounters usually last 10 minutes. How long are you lasting now? Well, I give up after 5 minutes, right? And so older men, because of stamina issues, strength and stamina issues, sometimes just don't participate in relations that are long enough to allow them to achieve an orgasm.
Mhm.
That's another kind of avenue of exploration that's worthwhile in a medical history.
Yeah, absolutely. I think that anyone who has sexual dysfunction has psychological components because it's stressful, right? Something's wrong with your genitals, something's wrong with your experience during sex, and you're stressed about it.
You know, one of my favorite Mulhallisms is you're only as good as your last erection,
Yeah.
right?
Yeah.
And so if your last erection doesn't live up to your expectation, and that doesn't have to be a hopeless erection, just isn't as good as you want it to be.
Mhm.
So some 25-year-olds want to be like 10 on a 10-point scale, and anything less than that's a problem.
Mhm.
But if that is happening to you, then you have anticipatory anxiety walking to the bedroom the next time. And of course, adrenaline is the world's most potent anti-erection chemical, right? So it causes the muscle to contract, and muscle in the penis, muscle relaxation causes erection, right? And so it opens the valve, and these are men who get, I get fully rigid, and I go to penetrate, and I lose my erection. They don't have venous lead. They don't have smooth muscle collagenization. They have adrenaline. And of course, the longer that goes on, the bigger the problem it is.
It is really truly a problem. And I think part of it is that men are not taught that their erections are going to fluctuate during the lifetime, and that some days you will not have as firm an erection as others. And so the second you have an erection that's less firm, you're stressed.
Yeah, and not even over one's lifetime, over, from week to week.
Yeah, exactly.
We've got lots of finance people in Manhattan who are like incredible stress,
Yeah.
right? So any stressor in your life can have a negative effect in the bedroom because adrenaline is an anti-erection chemical.
Yeah. And then penile sensitivity loss. With diabetics, you can try to improve glycemic control, but some of these are and nerves. And so are there techniques that you offer people with penile sensitivity loss?
Yeah, so first of all, from the chemotherapy standpoint, so let's say the cisplatin testis cancer patient treated with cisplatin, that's frequently temporary. It's not always, but it's frequently temporary. But for the diabetic, where it's an end organ damage and that's it, and glycemic control can help no deterioration of the sensation loss, but it's not necessarily going to improve the current sensation loss. We're big fans of penile vibratory stimulation. So we talk to all of our patients about the use of variable amplitudes penile vibrators. We do bioesthesiometry. We see that the sensation is markedly reduced. And we talk to them about PVS. And and we also talk about how they integrate that into lovemaking, right? So there are many men, I haven't had an orgasm with my diabetics, with my partner in 10 years. And I just pull out and I masturbate, or she masturbates me. Integrating a penile vibrator into cell for partner-based relations is, I think, a very valuable tool. Enhances intimacy, enhances the participation of the partner in the orgasmic kind of event. So we're big fans of PVS.